Welcome to the deep dive. Today we are taking a really close look at the body's largest organ, the skin. And it's so much more than just a surface, isn't it? It's our protective boundary, a fortress of these highly organized layers.
It really is. And we're going to be zeroing in on what happens when that fortress, well, when it fails. Our sources today lay out the anatomy, and then they dive deep into the major failure points. We're talking about peripheral vascular disease, both arterial and venous issues, and the really devastating consequences of pressure injuries.
And this is where it gets really interesting for us and for you, the listener. We're going to analyze the advanced clinical tools, specifically electrical stimulation and ultrasound, that are being used to aggressively kickstart healing right down at the cellular level.
Right. Our mission here is to connect all those dots.
Yes, to synthesize that whole journey from the microscopic structure of the skin all the way to these high-tech strategies that are used to reverse tissue destruction.
It's a perfect case of architecture meeting plumbing, you know? And you can't grasp the pathology without understanding that foundation. So let's start right there.
Okay, let's unpack this. We're talking about three main structural components. You have the epidermis at the very top, that's the outer shell. Then below that, the much thicker working layer, the dermis.
And then deeper still, you have the subcutaneous layer, or the hypodermis, which is sort of the padding and the anchor.
So that's the basic map.
That's the map. Now let's zoom in on that top layer, the epidermis. This is truly the ultimate barrier. It's made up of 5 distinct layers, and here's the critical part. It's entirely avascular.
Avascular meaning it has no direct blood supply of its own.
Exactly. No blood vessels.
That's just staggering when you think about it. I mean, this is the layer that's constantly renewing itself and taking all the abuse from the outside world.
It is. Its cells, including the melanin cells that give us skin color, they have to rely on nutrients diffusing up from the dermis below, which is full of blood vessels. And while all the layers are important, the most dynamic is the basal layer where new cells are born, and the outermost layer, the stratum corneum.
The stratum corneum, that's what we actually see and touch.
That's the one.
Yeah.
And it's just a genius piece of biological engineering.
Yeah.
That specific layer is much, much thicker on areas that take a lot of punishment, like the palms of our hands and the soles of our feet. It's like it anticipates the mechanical stress.
So beyond just being a durable surface, what are the primary jobs of this avascular layer?
Well, its core roles are, first, preventing water loss, which is crucial for homeostasis. Then it maintains overall skin integrity, provides that frontline defense against shear and friction, and it even has a biochemical job, synthesizing vitamin D from sunlight.
Which brings us down a layer into the dermis. If the epidermis is the self-healing armor, the dermis is definitely the engine room and the communication network. It's right below the epidermis, and it's the thickest layer of the skin overall.
This is where all the life support infrastructure is.
Mm-hmm.
The dermis has 2 layers, the papillary and reticular, and inside it you find everything. I mean, the entire blood supply, lymph vessels, a huge network of nerves, hair follicles, sweat glands, pain receptors, touch receptors. It's highly vascularized.
Which makes it central to healing.
Central to healing, but also very vulnerable.
And that vulnerability brings us right to our first major failure scenario. Pressure injuries. We hear about them a lot, but what's the immediate chain of events that turns simple pressure into, devastating tissue destruction?
It all starts when external pressure, usually over a bony prominence like a heel or the sacrum, gets high enough to physically collapse the tiny capillaries. It just squashes them shut.
It cuts off the blood flow.
It cuts off the blood flow. And if that flow is blocked for too long, the tissue experiences profound ischemia. It's starved of oxygen.
So not only are the cells starved of oxygen, but all the waste materials can't get flushed out, correct?
Exactly. Without fresh blood, all those toxic metabolic wastes just build up. This dual assault leads very quickly to tissue destruction and triggers this chronic runaway inflammation. It's like a biological chokehold that just kills the tissue.
And the forces causing this aren't just simple weight pushing down. There's this complex force triangle at play.
That's right. Compression is the main one. But you also have tensile stress, friction on the surface, and maybe the most dangerous one for deep injuries, shear stress.
Shear. Can you explain that a bit more?
Sure. Shear happens when your skin stays put, but the deeper tissues and bones slide. Think of someone slumping down in a chair. The skin on their back might stick to the chair, but the deep muscle and fascia get dragged downward, tearing away internally.
The impact of these injuries is just shocking. It's a common hospital billing claim, but the stakes are, they are genuinely life and death.
They really are. Pressure injuries can be gateways to systemic infections, like sepsis. The data we have shows an estimated 60,000 deaths per year are linked to these kinds of complications.
60,000. That number feels incredibly high for something that seems, preventable.
It is staggering. And when you look at the economics of it, you really understand why prevention isn't just a clinical goal, it's an economic imperative.
Right.
We're looking at $9 to $11 billion a year to the U.S. health system. But for a single patient, a severe stage 3 or 4 pressure injury can cost anywhere from $70,000 to $150,000.
That's more than a luxury car.
It is. It just drives home why understanding the root cause is absolutely non-negotiable.
Okay, so that need for prevention leads us directly into the bigger circulatory picture, which is peripheral vascular disease, or PVD. And that's the umbrella term, right? It covers both the supply problem, arterial disease, and the drainage problem, venous disease.
Exactly. Let's start with the arteries, the high-pressure delivery side, and peripheral arterial disease, PAD. This is basically about blockages that limit the delivery of that vital oxygen-rich blood.
And the blockage is almost always atherosclerosis, that word we hear all the time with heart disease.
It's the same process. It's the slow buildup of cholesterol and fatty plaque inside the arterial walls. When this happens in the legs, it narrows the pipe, limits blood flow, and critically chokes off the supply of oxygen and nutrients to the cells downstream.
It's just remarkable how many of the risk factors for this are the same across the board for so many chronic diseases.
They are almost entirely systemic. You've got high blood pressure, high cholesterol, tobacco use in any form, obesity, diabetes, chronic inflammation, age, and of course, family history. It's a full body problem that shows up in the periphery.
So when that blood flow gets really, really limited, when the cells are literally crying out for oxygen, what are the classic distinguishing symptoms you'd see?
The signs are pretty unmistakable because they're all tied to that lack of supply. First, you get intermittent claudication.
That's pain with activity, right?
Yes, pain in the muscles that comes on with activity, like walking, and goes away with rest. As it gets worse, it becomes rest pain, often at night. The leg or foot will feel cold to the touch. You'll find it hard to feel a pulse, or it's gone completely. And the skin itself shows signs of starvation hair loss, slow toenail growth, and eventually ischemia.
Ischemia, where the skin color actually changes.
It changes. It becomes dusky, dark, or even black.
Before we move on, how do clinicians actually measure how bad this is? How do you assess the flow?
Well, the standard assessment is first trying to feel for a pulse. Then you can use a handheld Doppler ultrasound to amplify the sound of the blood flow. And the gold standard is calculating the ankle brachial index, the ABI.
The ABI, let's just nail down that calculation because that ratio is such a powerful tool.
It is. You measure the systolic pressure at the ankle in one of two arteries there, and you divide that number by the systolic pressure in the arm. The resulting ratio tells you everything.
And a normal ratio is about 1.0.
It is. So if your ankle pressure is significantly lower than your arm pressure, that ratio drops below 1.0, and that's a huge red flag. The lower the number, the worse the blockage.
Got it. Okay, so if the artery side is a high-pressure supply crisis, let's pivot to the return trip. Venous insufficiency. This isn't about plaque. It's more of a mechanical failure, right?
Yeah.
Backflow.
It is, and it's way more common than people think.
Yeah.
Superficial venous insufficiency affects a staggering 30 to 50% of the adult population. It's a drainage problem. The blood just pools in the legs.
And what causes that mechanical failure in the veins?
The core issue is usually venous valve dysfunction. Veins have these little one-way valves to keep blood moving up toward the heart against gravity. When they get damaged or fail, often from high internal pressure, what we call venous hypertension, the blood flows backward and just sits there.
And the risk factors for that?
Things like immobility, a sedentary lifestyle, a history of DVT or deep vein thrombosis, obesity, pregnancy, and jobs where you have to stand or sit all day.
So because the blood is pooling, trapping fluid and heat, the symptoms must be very different from PAD.
They're pretty much the opposite. Instead of cold, the limb often feels hot or warm because of all that congested blood. You see spider and varicose veins, a lot of swelling or edema, and patients often complain about a tired, heavy, or achy feeling in their legs, especially at the end of the day.
Okay, so we've covered the mechanical breakdown of pressure injuries and the vascular crisis of PVB. Now we get to the fight back. How modern therapies intervene at the cellular level. We're focusing on electrical stimulation and therapeutic ultrasound.
Right, and these aren't passive treatments. They are designed to really coerce the body's own healing mechanisms into high gear. Electrical stimulation, or ES, uses a controlled electrical current to do two main things: improve local blood flow and directly fight bacteria.
You mentioned polarity is absolutely key here. Why does switching the electrical charge from negative to positive completely change the treatment?
It's a fascinating bit of biology. A negative charge, a negative polarity, is used in the early phases of healing. Its main job is to facilitate autolysis. That's the body's self-digestion of dead, necrotic tissue, and to ramp up the inflammatory response, which you need to clean out the wound bed.
So negative polarity is for cleaning out the junk and fighting infection.
That's a great way to put it. Then you switch to a positive charge, and the goal shifts entirely. Positive polarity is designed to stimulate the epithelial cells, the skin cells, to migrate across the wound bed. It's what actually closes the wound. It also helps guide immune cells like neutrophils and macrophages to the site.
That level of biological control is just incredible. The sources mention very specific parameters, too. 100 pulses per second, up to patient tolerance 150 volts for a 45-minute treatment. But when is this powerful tool absolutely off limits?
Safety first, always. The contraindications are strict. You can't use it if there's an active untreated infection, any active bleeding, or if there are topical agents with heavy metals on the wound. Also, no go for cancer in the area. And critically, if the patient has a pacemaker or an internal defibrillator.
Makes sense. Okay, let's move to the second modality, therapeutic ultrasound. This sounds less electrical and more mechanical, using sound waves.
That's exactly it. Ultrasound uses sound waves to create a mechanical effect at the cellular level. It changes cell characteristics through two main processes, cavitation and microstreaming. You can think of it as a deep, targeted micromassage.
And what do those mechanical waves actually do to the cells in the tissue?
They trigger a whole cascade of therapeutic actions. One of the most important is that they increase the permeability of the cell wall. This is vital because it lets necessary ions and nutrients move more easily across tissue barriers that might be compromised.
So if you have this ischemic damaged tissue, increasing permeability helps flood those cells with what they desperately need to survive and rebuild.
Absolutely. The mechanical action also boosts overall cell activity. It aids in protein synthesis, triggers the release of growth factors, and helps organize the fibroblasts and the new collagen that's being laid down. Essentially, ultrasound helps the cells build a stronger, better organized repair patch, which is so critical when you're fighting that deep damage from pressure and shear.
Wow. So we've gone from looking at the 5 tiny layers of the avascular epidermis all the way to using electrical currents and microvibrations to literally coerce cells into cleaning wounds and healing properly. I mean, this deep dive has really shown the intense vulnerability of our skin and the incredible sophistication needed to fix it.
We started with that foundation, a vascular barrier in the vascular engine room of the dermis, and then we looked at the two main ways it fails. First, the mechanical failure of a pressure injury, where external force just chokes off blood flow.
And second, that vascular crisis of PVD, whether it's the lack of supply in PAD from atherosclerosis or the backflow and congestion from bad valves and venous insufficiency.
And finally, we saw these highly targeted responses. Using electrical stimulation where you can literally flip a switch to change the cellular goal, and using the mechanical action of ultrasound, the microstreaming and cavitation, to promote everything from protein synthesis to good, strong collagen organization.
So what's the big takeaway here? When we look back at those staggering figures, that $150,000 cost, the 60,000 deaths tied to severe pressure injuries, it completely reframes the whole battle.
It does, and it raises a really important question for you, the listener, to think about.
Yeah.
If you consider those intense localized stresses, the compression, the shear, the friction that cause these deep, devastating pressure injuries, how fundamentally important is the successful organization of collagen, the stimulation of protein synthesis, and that controlled cell migration? These are the very processes that therapies like ultrasound and ES target. It really emphasizes that the true healing battle, the most expensive one, isn't fought with bandages. It's fought at the level of cellular engineering.